Welcome everyone to today's webinar entitled Marijuana and Breast Milk. This is hosted by the Maternal Substance Exposure Database, which we call MADEX, through CPQCC. If you have any questions for myself or for our speaker, please send that over in the chat. There's also a Q&A function that we're asking you to use, so that use the chat maybe for technical issues that you're having. As I've mentioned before, if you're just joining us, there is a link on the screen. You can type that in bit.ly/THC and Breast Milk, and that will take you to a really short survey that we're asking attendees to complete. We'll share the survey results with you later, so we promise it'll be interesting the more people that do it. But if you can go ahead and fill that out, we would greatly appreciate it. Here's a brief overview of what we're hoping to talk about today. So we'll do a welcome, a presentation that'll be about 30-35 minutes. We'll share those survey results and then have time for a live Q&A. So as you're listening, if you have a question, please feel free to submit that in the Q&A box. The Maternal Substance Exposure Database, that's the group that's hosting this webinar today, is an optional and free database that's part of the California Perinatal Quality Care Collaborative. You might be familiar with us, CPQCC. A lot of you are from California. So we collect data on all maternal substance exposures. So those include, but aren't just limited to, opioids. And by doing that, we aim to improve healthcare for exposed newborns by focusing on treatment and length of stay in the hospital. And while the database is designed to capture information on infants who have been exposed to opioids, many of our members also use it to collect data on infants who have been exposed to other substances as well. So about 23% of our infant records in MADEX report maternal exposure to marijuana. We would assume that the rate for this data is much higher, since a lot of our MADEX centers do primarily use the database for opioid exposed infants. So this is an example of the MADEX report site, where if you join MADEX, which again is free and optional, you can compare your hospital to other MADEX participating hospitals. So we have 32 right now across California and over 500 infant records that have been entered to date. This data is used to drive improvements in the care provided to exposed infants. This is done through a range of reports designed to help you identify areas of high and low performance, monitor the effects of improvement interventions, and conduct research that advances the quality of care. MADEX is available and free to all CPQCC centers, but you do have to request access. So if you'd like more information on MADEX, send us a message in the Q&A or in the chat with your email. You can also submit your email in the evaluation survey for today's webinar. So again, this is, I'll say this one more time. So please take a minute to answer the following survey. You can type this in, THC and Breast Milk. The slides will be available afterwards as a PDF for download, and I'll send around that link. We are really excited today to welcome Dr. Christine Bixby as our speaker today. She is board certified in pediatrics and neonatal perinatal medicine. She completed both her pediatric residency and neonatal perinatal medicine fellowship at Harbor UCLA Medical Center. She attended medical school at the University of California, Davis, and she is a practicing neonatologist at CHOC Children's Hospital. She is an international board certified lactation consultant in IBCLC and the lactation medical director at CHOC Children's Hospital, where she focuses on breast milk handling and breastfeeding support in the NICU. She is a strong advocate for breastfeeding in Orange County through the Orange County Perinatal Committee and the Orange County Breastfeeding Coalition. She has published and speaks frequently on best practices in breast milk handling and optimizing breast milk production and breastfeeding in the NICU. Welcome, and I will turn it over to you, Dr. Bixby.
Hello, thank you very much for inviting me to speak. It is my privilege to get to talk to you about cannabis and breast milk. let's hash it out. And I will do my best to minimize the number of dad jokes, but I had to put that one in there. It is quite the appropriate day. As you note on the bottom right corner, Cannabis 420. It is the most sacred and celebrated day for marijuana. And so it is very appropriate that we are talking about it today. Next. So my disclosures are limited. I am faculty for the Small Baby Care Specialist Program from Engage, Grow, Thrive, where I shockingly talk about optimizing milk supply in the NICU, the benefits of human milk in the NICU, and how to handle human milk in the hospital setting. I'm also a consultant for Willow breast pumps as well. Next slide, please. So here's our big question, and it's the question I get asked as an MD IBCLC all the time is it okay for a woman who tested positive for THC to breastfeed or express milk for her baby in the NICU? And I think the easiest way to answer it is it's complicated, and I'm going to walk you through it. This question kept coming up a lot. In 2018, I decided to deep dive into the data to be able to come up with a comprehensive understanding of what is known and what isn't, and also to be able to give my colleagues and our group, of which is a number of NICUs, some education and knowledge and maybe a consistent message around the concept of THC and breast milk. So to answer the question, you get two more questions. So next slide, please. One, and this is for any substance that crosses or that you're seeing a breastfeeding mother use, is does it cross from the mom into the breast milk? And if it does cross, is there harm to the infant? So we're going to go after the next question, the first question, which is, what is cannabis? And cannabis is a plant, as you see it on the right up corner. It's Cannabis sativa. It has over 150 known compounds. It has increasing potency over the decades and by location. Of note, between 1995 and 2014, the potency or percentage of THC has increased from 4 to about 12%. There are some products that are made in Washington State with flower products greater than 20% of it being THC, and with their extracts having greater than 60% of THC. And we'll get into what THC is in a little bit. There are various forms of consumption, the good old fashioned cigarette or joint, using a water pipe or a bong, my aunt and uncle's marijuana brownies, the more common and newer versions of vaping, and then this new thing to me called dabbing, which is where they pour butane over the plant and you get a sticky precipitate out that you can then smoke that allows you to have a much higher concentrate of THC with a very rapid onset. Important to note that with consumption, if you're smoking, you're going to have rapid onset as it goes through the lungs into the plasma, versus consumption of brownies or gummy bears, that's going to take over 30% or 30 minutes, and your oral bioavailability is fairly low. Other thing to note about cannabis, there are other additional unknowns as the growing of the product is not technically regulated. So there is potential for lead, mold, pesticides, rodenticides, herbicides, and fertilizers in the product, and we don't know what they are. Next slide. So two components of cannabis that everybody is very known in common colloquialism is CBD or cannabidiol, which is a phytocannabinoid that's extracted from the cannabis plant and then diluted with the carrier oil, usually a coconut oil. Not a lot is known about CBD. It's felt to be less psychoactive. And I'm not going to talk a lot about CBD at this point in time because of the lack of significant data. The big thing that we're going to talk about is THC, or delta-9 tetrahydrocannabinol, and I'm not going to say that word again. We're going to call it THC going forward. And it is the most psychoactive component in marijuana. It has a very large volume of distribution, and it enters the plasma compartment almost instantly from the lungs and then redistributes to highly vascularized tissues such as the brain and the liver. It's highly lipophilic, so it likes to store in fat and can be there for weeks to months. And important to note, the half-life of THC is fairly long. In infrequent users, it's 20 to 36 hours. And in chronic users, it can be about 4 days. We'll talk about further data that's come out just in the last few months about even a longer half-life. Of note, it is present in the exhaled breath for 2 to 4 hours after one cigarette. And I think this is an important thing for those of us in the newborn intensive care unit where we're putting babies skin to skin appropriately for moms to smell the environment around their babies so they can have that IgA exchange into their breast milk. But it's important to encourage moms, if they are going to be using cannabis, to do that after they've done their skin to skin and to maximize the time from smoking to when they actually do skin to skin with their infant in the NICU. Next slide, please. So where does THC function? And THC functions in a lot of places. And I think the big area that everybody likes to talk about and where we have some information and some data in both human and animal is the endocannabinoid system. And I will admit that when I heard endocannabinoid system, I think I've heard of that, but it was not a strong system that I remembered from medical school, but it kind of works everywhere. So THC functions with the endocannabinoid system as an agonist to the cannabinoid receptors, where it impacts neuronal cell migration, proliferation, and differentiation, which impacts attention, cognition, memory, emotion, movement, and the peripheral immune system. So in particular, it's hitting in these executive function areas. And we'll see that as we go through some of the data that I'm going to highlight. THC also functions within the dopamine, opioid, GABA, glutamate, and serotonin associated symptoms, so kind of everywhere. But these are areas where you're looking at reward centers and emotional regulation as well. And then it's also seen to promote corticotropin secretion and preventing the secretion of gonadotropins, TSH, prolactin, one of our big breastfeeding hormones, and growth hormone, where there is some data on fetal exposure with concern for growth restriction, which I do not have time to go through at this time. Next slide, please. This is just a quick review of the uses for cannabis. I'm not going to read through it for you. Of note, recreationally has become a very important and significant area of cannabis use in the current times. Next, please. So let's talk about THC and breast milk. And so we're going to now get into the weeds of, does it transfer or not? So what factors increase the likelihood of passage into breast milk? And it's important to note that certain things pass very easily and others do not. You have a low molecular weight, so less than 300 Dalton, and marijuana in particular is a 314 Dalton chemical, so it would pass in that regard. Low protein binding facilitates transfer, although THC is more commonly protein bound. Weakly basic, being lipid soluble, which we know THC is very fat soluble, that's that lipophilic. High oral bioavailability. THC is about 4 to 12%, so that's not on the high side, but there is some oral absorption. And that's where we get into that question of, if it gets into the milk, is it enough that it is actually causing getting to the baby? And we'll talk about that in further slides. And do we get a high maternal blood level? I would argue that in some of these situations where mom is smoking something with a 60% THC, we could see very significant maternal blood levels, or if she's a chronic user and has significant stores, and we'll go over some of that data. And then is there a long half-life? And like we talked about, 36 hours, 4 days, that's a pretty long half-life. So there is good argument that THC could pass into breast milk. So this is a review from Moore in 2017, looking at data, looking at THC transferring into breast milk. And then does that breast milk, once it gets into the milk, actually result in positive findings of THC in the infant? And this is a 3-page slide. I'm not going to show you it all for the sake of time. The other 2 slides are mostly animal data. So if you want to explore that, you can look, pull up this paper. It's quite easy to find. The red boxes are pointing out some of the interesting things. And when we talk about it over the past many years, the argument was that it's an 8-to-1 and that you get an 8 times dose of THC in the infant relative to the maternal plasma level or the milk level. So this first paper, the Perez, Reyes, and Wall paper, which is from very recently, called 1982. I was 10 years old almost. So it's been a while. It's old data and it's small data. It's 2 women. One woman who used every day for 7 months and breastfed, and they did demonstrate that there was marijuana in the breast milk. The other one is the reason why we had this 8-fold increase in THC that got everybody very concerned. And this was a mother who smoked marijuana 7 times a day for 8 months. And in this sample, we did see that there was 8 times more THC in the breast milk than the blood plasma of the mother. And that we were actually concentrating THC in the milk, and it made for significant concern. And that, are we giving a really high dose of THC to babies? And then they did evaluate the baby's stool and found that there were metabolites that showed that the baby actually was receiving the THC and metabolizing it and excreting metabolites. No, it wasn't just metabolite because it was in the breast milk itself. So that paper told us that THC can cross, and it's potentially crossing in a very high concentration, and it's sequestering in the milk, which made things very concerning. The Ahmad and Ahmad paper from 1990 was an interesting study of buffaloes that apparently ate marijuana about 5 to 10% of their diet, and then looking at if the children who drank that buffalo milk, did they have THC in their in their urine samples, and 29% of those children do. So the argument there was that yes, you did even have it from animal milk exposure. You can see THC. Next slide, please. So the good news is we have more recent data that conveniently came out. The first time I did this deep dive was in 2018, and very kindly, the 2 studies, the Hale and the Mommy's Milk studies, came out right when I was looking at the data. And they were, we've known about the Colorado study for a while. And Thomas Hale, who is a pharmacist and is kind of the resource for what is safe in breastfeeding when it comes to medications and substance exposure, he had started enrollment on a study in Colorado after marijuana was legalized. And we were all so excited about this study and hoping it was going to give us so much information. And it was kind of a letdown in some regards because they were only able to enroll 8 mothers, even though it was an anonymous study, and only 5 of those mothers actually completed the questionnaire. But this study was, the women abstained from using marijuana, then went to a very specific dispensary and picked up a very specific marijuana that they knew the dose of THC, and had them pump, smoke, and then pump over interval periods of time to see if there was THC in the breast milk. There is no serum data for this study. And the RID, which is the relative infant dose, which is the daily infant dose in milligrams per kilogram of infant weight over maternal dose, which is milligrams per kilogram of maternal weight times 100. In general, the relative infant dose, or RID, if it's less than 10%, when you're looking at medications, it's felt to be safe. I will note that even though he did see this 2.5%, it was based on 150 cc's or milligrams per kilo or milliliters per kilogram per day of intake. And he has not updated his recommendation on his resource to put in a defined RID. I think he is appropriately recognizing the numbers are too low to make a definitive statement. He did note that the THC dose peaked at an hour and then slowly decreased until the end of collection. So the takeaway from the Hale study is that THC does get into breast milk. As we move on to the Mommy's Milk study, which was done through the group at UC San Diego, they looked at 50 women with 54 samples, and they had mothers recall their exposures for the 14 days prior to milk collection. So this is just recollection. And then they tested the milk samples. And the big finding from this paper was that THC was detectable up to 6 days after the last reported use. And then as I'm re-upping this study, it's very kind again, new papers have come out, and the Moss study out of Oregon just came out this year. And that looked at 20 different women who provided samples at the 2-week and 2-month pediatric tests or visits, and were known to be using marijuana. They were found to be increasing their use between the 2-week and 2-month pediatric visit. And all but one had at least 1 cannabinoid in their milk. And there was the presence of CBD, even though there was no report of use of CBD. So I think we're getting a compelling statement that an idea that even though the numbers are small, we're getting a consistent data now that says, yes, it's not just these 2 women, but we've got a lot more that's saying, yes, THC does transfer into the milk. Next slide, please. This slide, I think this is an interesting concept because this is the one where what happens if we abstain? So this is a study looking at, and just published, but this is the Weimar paper, and it was just published March of this year. And it looks at women who were frequent users, greater than 2 times per week prior to delivery, who then abstained from using cannabis postpartum. And then they donated their milk and blood 2 to 5 times per week for 6 to 7 weeks. I feel like this is a really labor-intensive study. But what they found was that the maximum milk THC levels were 2.8 to 26, and the elimination half-life from milk averaged 17 days. And I think the important thing when you look at the graphic on the right is that the bottom axis is time in days from delivery and abstention. And what you're seeing is you still have a milk level of THC at 40 plus days. And this is something that I don't think any of us expected. It's something that we were concerned maybe there. Now, these are fairly heavy users, but it is something that we need to take into account as we evaluate our concerns in regards to THC in the breast milk. So next slide, please. I think we've answered the question, does THC cross from the mother into the breast milk? Absolutely. Now it's time to go, okay, if it crosses, does it get to the baby? We think it does. There is some amount of oral bioavailability, but does it cause harm to the baby? Next slide. And I think inherent to the fact that cannabis has been illegal and folks haven't really wanted to be like, yeah, I'm breastfeeding and smoking, because there is that inherent risk, legal risk, plus people's particular bias or response, there's not a lot of data, and there's not a lot of let me jump into a study and be a part of it, which is what we saw in the Hale study, in all of those studies just looking at milk transfers. You're not able to recruit huge numbers. So we kind of have to look in other places. And so I'm going to start with looking at what is known about cannabis exposure in the teen brain, and then look at some of the data in pregnancy and utero, which often spills over into postpartum exposure and breastfeeding. And then get into what we do know about breastfeeding cannabis, what little outcome data there is, what the current recommendations are, and then we'll get into the NICU patient and look at our approach at CHOC Children's. So before I get into the weeds of outcome, it is important to note that there is no reliable biologic sampling method to quantify the amount of marijuana use. I can't get a level like you can with alcohol and say, oh, this person's drank a lot, or this person has drank a little. We really have to go based on self-report. And self-report is inherently biased. Some want to report more use than they actually are to have that perception of them. Others don't want to report their use at all. The other issue with data in regards to THC and marijuana use is there are often confounders. There's often polysubstance abuse with tobacco, alcohol, and other illicit drugs. So the likelihood of a pure study with no exposure to other agents, I think, is exceptionally low. Next slide. So what do we know about the teen brain, and why do I want to talk about the teen brain? And the rationale for the teen brain is really that there's still changes going on and maturation of axonal tracts and networks in the teen brain. So we have a developing brain. And so does THC affect that brain? And in telling folks I was doing this talk, I said, oh, I was going to talk about teens. And in my mind, when I think about teen and marijuana use, I think of Spicoli from Fast Times at Ridgemont High, which then they all look at me like I don't know what I'm talking about, because apparently I've become old. So let me walk you through some of the things that we found that kind of go inconsistent with that meme type of that person in that movie. And that is that we do see short-term declines in attention, executive function, and memory. With regular use, they noted an 8-point decline in IQ when you evaluated a teen marijuana user at the age of 38, and that would persist even if they stopped using. Chronic use in the teen years, you can see reduced brain volume in memory centers like the hippocampus and amygdala. And that is also seen in the chronic adult brain, where you see decreased volumes in the amygdala, hippocampus, and parahippocampus. Chronic users also, when you do functional MRI, show impaired axonal connectivity in the white matter, and that is worsened if they have earlier age of onset of use. So we do see attention, executive function, and memory affected by their exposure to marijuana, as well as changes within the brain itself. Next slide, please. So what is known in pregnancy in utero? And I'm going to start with the animal data, and then we'll move into the human data. And this is a summary by Navarrete looking at preclinical findings for perinatal cannabis exposure. So this is both pregnancy and breastfeeding, which is generally what we're going to find. If you're using marijuana during pregnancy, I was impressed to see this new paper from Wymore, because it's often hard to find someone who thought that it was okay to use marijuana during pregnancy and that they did not want to continue post-delivery. So they go through in this graphic kind of summarizes things that, since we don't have time to get really heavily into the weeds, there are specific neurobiological alterations that I'm not going to read all of those out, but they result in behavioral alterations that you can see on this of the right-hand side, which is motor impairment, cognitive deficits, decreased social interaction, increased vulnerability to reinforcing and motivational effects of drugs of abuse. And that's what you're looking at with your dopamine receptors and your similar receptors that we talked about where THC functions. And so this is kind of, we're going to start seeing this theme. We see cognitive deficits in the teen, and now we're seeing it in the rat that's exposed. And now we'll go ahead and move on to the pregnancy as well. And so what do we know about pregnancy and marijuana use? 36% use at some point in pregnancy. Use declines over gestation. And if they're using at term, then they are likely a chronic or dependent user. 48 to 60% will continue using through pregnancy as they feel that tobacco is a safer alternative, or that is safer than tobacco. Of past users at between 2007 and 2012, 16% of pregnant responders were using daily, and 18% met the criteria for abuse or dependence. Next slide. So I'm going to talk to you about the big three prospective trials: the Ottawa Prenatal Prospective Study, or the OPPS, the Maternal Health Practices and Child Development Project, or MHPCD, and the Generation R study. And when we look at this next slide, it's a lovely table that kind of summarizes, and I don't have the time to go through all the data, but I'm going to hit the high points real quick. The OPPS is a study that was done in Ottawa, started enrollment in 1978 in a primarily middle-class Caucasian population. MHPCD began enrollment in 1982 in a largely African-American population in a low socioeconomic status in Pittsburgh. And then Generation R is our new study in 2001, which is from Holland, which is a multi-ethnic cohort, but they do have a slightly higher socioeconomic status. I think just based on the years of enrollment, we can state that the amount of THC in product that they were exposed to is going to be a lot higher in the 2001 versus the Ottawa and Pittsburgh studies. As we go down the graphic, the polysubstance abuse is notable to be across the board present. So we're going to have confounded data no matter what. And then we will look and see retention is actually, I think, impressive, 63% all the way to 22 years. And then even looking at 80% to 22 years on the Pittsburgh study. The Generation R study is still following up, and they have the 6-year data that they've published, and that has exceeded 80% for retention rate. As we move into the outcomes on the next slide, we'll see that one, there's some trend unclear about preterm delivery and birth weight. And that, I think, is still teasing itself out in the literature. And we really need to jump down into the preschool, school age to start looking and seeing what they saw as a trend. And it's important to note that they're seeing similar things, especially between the two studies in the 70s and 80s. In the preschool population, we're seeing verbal and memory performance is affected. And then when we move into school age, we're seeing attention, impulse control, hyperactivity, visual reasoning issues, executive function problems, language comprehension, reading, spelling, and academic achievement. So we're seeing issues that are going to show up more about 8 to 10 years of age. And it's that reading, writing, academic performance, which is a significant issue. Now, could that be confounded by the polysubstance abuse? Absolutely. When we move into the teen and young adult period, we see persistence of some of this higher level executive functioning, visual cognitive functioning, academic achievement, particularly in reading. And then as we move to the very bottom, we're going to see issues with smoking, early substance abuse, chemical dependence. When we look at Generation R, we're still really early into the data. And they do note that between 6 to 8 years, they saw altered brain morphology in the frontal cortex. And I think we're still, this one, the jury's out yet. We've got to give them the time to follow over time in order to give us the actual good data that I'm hoping they will give us from this study. Next slide, please. So now I'm going to actually look at breastfeeding and cannabis, because I've looked at the teen, we've talked about the pregnant, and then subsequent potential breastfeeding exposure there. But what do we know specifically about cannabis and breastfeeding? So as we saw in the Wymore paper, maternal use does increase in the first 6 months postpartum. What also is important to note that THC and cannabis absolutely has a potential for affecting lactation, as we see a decrease in prolactin levels and a decrease in the oxytocin levels. These are the two big hormones of breastfeeding. Prolactin is your make and milk hormone, and oxytocin is your letdown hormone. And if we're seeing those, there would be concern if those are lower that it would impact your breast milk production and your ability to maintain a milk supply. So what we do know is that women who smoke cannabis, it does not affect whether they will initiate breastfeeding. They have the same initiation rates as the general population. But when studied at a greater than or equal to 9-week postpartum, you see a statistical decrease in breastfeeding if mom is using marijuana. And it's unclear if that is due to the decrease in the hormones, which one could argue it could be, or if it's due to other things such as social stigma, et cetera. Next slide. When we get into the weeds of the logistics of breastfeeding and THC, it is important to note, especially if mom is smoking her marijuana, that there is an independent twofold increased risk for sudden infant death syndrome. And I think that's an important point. It's not part of smoking cigarettes. So cigarettes we know has an increased SID rate. This is on top of that. And so it is very important, I think, to educate mothers that they should smoke outside if they're going to do it, to minimize that risk. When we look at the data on breastfeeding and THC, there are no isolated studies without in utero exposure. So the data is never going to really be pure. We're going to have to deal with the fact that it's likely we're going to have a prenatal, postnatal exposure between the prenatal exposure in utero and the breastfeeding exposure. And the evidence that we have, which is very small currently, on the effects of THC on infant development is sparse and conflicting. And I'm going to run you through that now. 2 papers that are referenced, if you look at any review, LactMed, et cetera, you're going to see these papers referenced. But again, this is data that's not too recent. The tennis paper was from 1985. It looked at women who were using marijuana while breastfeeding and compared them to controls. There was no comment on whether marijuana use was occurring during pregnancy or not. They assessed the babies at 1 year with the Bailey scales of infant development. And for those who don't recognize the term Bailey scales of infant development, that is a assessment of an infant done about 6 months on onward until about 2 to 3. We use it in the high-risk infant follow-up clinic to assess fine motor and gross motor development, as well as psychosocial development as well. So it's one of the tools that we use consistently to evaluate infant development. In the tennis paper, they saw no difference in motor and mental development. When we moved down to the Astley and Little paper 5 years later, they had a little bit larger cohort of 68 babies in each group. Both groups, mothers used marijuana during pregnancy. The exposed group continued to use marijuana after in the first and the third month of postpartum while breastfeeding. They assessed at 1 year of age using the Bailey scales of infant development. They noted that at higher exposure, you saw a lower psychosocial developmental index, and as well as you saw a decreased motor developmental interest on the Bailey as well. So there's no difference, there's difference. And it's small data, so it's hard to really hang your hat on it. And it really hasn't been able to be reproduced, partly because I think it's very hard to recruit into this patient population. Next slide, please. So I don't have the time to run through all the animal data, but I'm going to give you the statements from 2 organizations about long-term concerns about effects on the infant. The Academy of Breastfeeding Medicine, which is an organization of physicians who support and advocate breastfeeding, in their review, noted that the number of studies that have found concerning evidence, both human and animal, outnumber the studies that have concluded no effect. A conservative approach is suggested until evidence can strongly support otherwise. The AAP, or American Academy of Pediatrics, in their clinical report, noted that their current understanding of the ECS, or endocannabinoid system, and its role in the development of neural circuitry in early fetal life also provides theoretical justification for the potential of marijuana substances, particularly THC, to affect neurodevelopment. So there's concern. Next slide, please. So what are the current recommendations? And I'll start with Hale. He's the guy out of Texas with the Infant Risk Center, or Mommy's Meds, or Milk and Medications. And he has the rating scale of L1 through L5. I'm imagining that many of you recognize that scale. And L1 means that there is no risk, or there's perceived to be no risk, and there is some data potentially that is supporting its use. L5 would argue that there's significant risk and you should not use that substance while breastfeeding. L4 is often considered one that you shouldn't use while breastfeeding as well. So he's saying limited data, possibly hazardous. I've underlined this statement he added recently in the last few years. And it says, well, this data poses numerous limitations and does not directly examine the benefits of breast milk versus risk of exposure to marijuana and milk. Cannabis use in breastfeeding mothers should be discouraged at this time. And I think his point is valid in that there's a benefit to breast milk. We know that long paper from 2012 from the AAP with the graph that shows all the different percentages of improvement in milk in outcome when you're exposed to maternal milk. But then there's a risk to marijuana that we don't know. And we don't, I worry that it's going to be hard to find this pure data where we're really able to analyze the benefits of breast milk and the risk of exposure to marijuana. Next slide. So the recommendations are to avoid further use from the ABM, AAP encourages to abstain, the CDC encourages to abstain, and the ACOG, marijuana use is discouraged. So where do we go from here? In summary, we know THC crosses into breast milk. There's concern for marijuana exposure in all ages, particularly in the developing brain, but the data are imperfect. Realistically, excellent data sets are not likely coming, at least in the near future. And we're looking at if we think impact is of an executive function, we have to wait until these babies reach an age where they're actually utilizing executive function, which is going to be closer to 8 to 10 years, and then seeing what that looks like in fallout. And then one must recruit. So it's kind of similar to the Generation R. They recruited in 2001. We still don't have great data on how if there is impact on executive function. And our recommendations aren't particularly helpful from the organizations. Discourage, abstain. It's not a definitive moment where it tells us what to do, particularly in regards to the preterm population. Next slide, please. So again, we're back to the question, is it okay for a mom who tested positive for THC to breastfeed or express milk for her baby in the NICU? And I think the answer is it's complicated, but how do we approach it? Next slide. So there's none of the data and none of the recommendations really discuss the preterm or the NICU patient population. And I think it's important to note that most of our infants who are admitted to the newborn intensive care unit have an inherent risk of neurodevelopmental delay due to their underlying diagnosis and subsequent need for neonatal care. The AAP, of course, supports human milk in the preterm and NICU population, but has not given us any guidance on how to address marijuana using mothers in the NICU. Next slide. So how do we develop a recommendation in the NICU? And I do think it is each unit, because the data isn't definitive, there's a lot of concern, but it's important that we look at what the patient is bringing to us and what we have as options as we evaluate our potential recommendation in our unit. So first, how frequently is mom using? When was her last use? Is there polysubstance abuse? Is there maternal willingness to discontinue use? Is there an ability to develop a trusting and therapeutic relationship? Is there availability and reliability of donor human milk? And what's your NEC risk in your unit, particularly when dealing with your higher NEC risk populations? Next slide, please. So there's 3 possible approaches. And I think that you could argue, based on what your availability of and ability to answer the questions previously, how to approach it. So number 1, you could just say, you know what, we're going to use breast milk for all marijuana users and go with the belief that breast milk is really going to mitigate any potential risk that we don't know is coming from use of marijuana and getting into the breast milk. We could also, the second approach would be to pump to establish supply while mom abstains and utilize donor milk until some time that the THC level in milk may theoretically be low to 0. And then finally, you could say, you know what, mom's used marijuana, we're not going to use her milk at all, and we'll just use donor milk because we have such easy access. And we really feel that the risk of marijuana is significant, and we don't think it supersedes the benefit of what is concerned, what we gain from being exposed to mother's own milk. Next slide, please. So I'm not giving you an answer, unfortunately. I'm going to give you our answer at the Children's Hospital of Orange County, which is our CHOC stoplight approach. And I'll walk you through that. Next slide, please. So where are we and what are we? CHOC is a 334-bed tertiary freestanding children's hospital with a 104-bed level 4 NICU in Orange, California. We have a robust and liberal donor milk policy. We will give donor milk to anybody in our NICU. A part of that is because we are very successful in establishing milk supplies in our mothers. And so it is a small portion of our population that doesn't have mother's milk in large volume. And so it's often a bridge, but it's available to all comers. And then we also have a strong lactation team where we are able to support moms and engage with them in establishing milk using a pump. Next slide. So our approach is multidisciplinary. The nurse, the doctor, the LC, the dietitian, and the social worker are all engaged and involved in this process. We identify a THC positive mother, and she is evaluated by the lactation consultant. This interaction is respectful and without judgment. Mom is educated on concerns surrounding marijuana exposure and possible risk to the infant, particularly in the NICU patient. And then we identify mom's lactation goal. Does she want to breastfeed? And then we ask, when was her last use? Was it less than or greater than 2 to 3 weeks prior to delivery? And does she plan to continue or stop her marijuana use? Next slide. So our approach, the easy ones, if mom plans to continue to use, we prefer to use donor milk, as the unknowns we feel is too risky to use in our NICU population. And we will use donor milk throughout the NICU stay and transition to formula prior to discharge. If mom's use is greater than 2 to 3 weeks prior to delivery and she plans to continue to abstain, we will use her milk immediately. If mom's in that middle zone of having used within 2 to 3 weeks, but she does take the education and she does plan to stop using, we choose to go with using donor milk for the first 2 to 3 weeks, have mom pump and fertilize. I don't think one should ever dump human milk, so I do have them fertilize a plant. No maternal milk will be collected in our centralized nutrition lab where we do milk handling. Our diet order will be only for donor milk, with the date to reassess in that diet order, so we can see if we can start using at that time. Mom is educated by the lactation consultant on how to establish a milk supply using pumping, hands-on pumping, frequent skin to skin, and regular pumping. At 2 to 3 weeks, the lactation consultant will check in with mom and we'll see if she's continued to abstain. her transition, if she says she has, we will transition to use her milk. We get to change the diet order and the nutrition lab begins to accept milk. If her, that's it, sorry, excuse me, next slide. So that's our approach. It's an approach. Is it perfect? No. We've had challenges in that we've had issues with team member buy-in. Part of it was education. This slide deck was initially built to roll out and educate my colleagues on why we had significant concern. Defining roles was another challenge, as we had to make it so that people could, who was responsible for picking the date? How did we communicate that date? And then when did we go forward with changing the plan, and how do we communicate that plan? And then what are the exceptions? And the exception's always there, and it's a challenge and a success. And the mom who's got a trisomy 18 who wants to do palliative care, we're going to let her use her milk in our unit, and we don't want to confuse the message, so we message around that exception correctly. Our successes are we've been able to generate and develop a consistent message, and then when we get to change the diet order to use breast milk, and then again, that exception where we're able to message appropriately that we're making an exception because it's the right thing for this family. Next slide. This is a visual of our algorithm. The middle is the cannabis. Below the dotted line specifically defines whose role the doctor, the LC, or the nutrition lab, and what they do in each setting. I'm not going to go through it for the sake of time since I'm already gone over. And next slide. I think we are done. I think we just have references and cute pictures of my breastfed babies, because we always have to end with breastfed babies. So I thank you for your attention, and I look forward to our discussion.
Thank you so much. So I'm going to actually start with Q&A and give people, we've had almost 150 responses on the survey, which is great. So I'll give you just another, like a minute to do that. If you haven't, the link is there on the screen. But to kick off our Q&A, and there are a lot of them, so I'm just sort of choosing ones that we haven't really addressed yet in the conversation. What are the legal ramifications around this topic? So some things that were brought up. If you withhold the mother's breast milk, is that a problem? What if there are adverse effects for the infant from using breast milk that has THC in it? What about CPS involvement? Yeah, could you speak to that a bit?
Yeah. I actually I've had this come up from colleagues saying, well, you know, the recommendation, do we have legal exposure because we refuse to use the mother's milk? And I've actually even run it by our risk folks to just make sure that we don't have legal exposure, because it seems to make sense that if we're going with the conservative baby's best interest, and because the recommendations are abstain, discourage, basically do not use, we are okay with following those guidelines, and it is there is no risk from a legal standpoint from their perspective to use donor milk and not use the mother's milk, which makes sense if you think about alcohol. You're not supposed to, you know, really shouldn't, but you're discouraged to not use a ton of alcohol during breastfeeding. If I have a mom who's a severe alcoholic, I'm not going to use her milk as well. And when we look at things like allowing moms to use, I think the important thing is that if your unit needs to proceed in that fashion because you have you don't have availability of donor milk and you have a 24-weeker and a high neck rate, you're probably going to choose to use that milk. You're going to educate the mom extensively saying we need to use your milk to decrease the risk of death or severe complication from necrotizing enterocolitis, but we really think you need to stop, and here's the reason why. So I think as long as you disclose and educate, I don't think there would be liability from allowing use if your unit is in the situation where it makes more sense to do that. Referring to CPS, I think, tends to be more social work and unit practice. I think that there's often, if there's use, that referral will happen, often more just to check into to whether there's a file on the family and to make sure that it has been communicated if there's concern. It's often more than just the THC use alone that gets a call to CPS.
Thanks. A couple questions about CBD oil. You mentioned that at the beginning. Do we know anything about CBD in breast milk?
Not really. And I think part of it is we're still getting just the minimal teeny amount of THC data. So my hope is that we will see that coming, as CBD has become a very popular product that people are using for almost anything at this point in time. I think it is important to note in my review of all the literature, and I will say this talk was very narrowed down. I could have gone on for 4 hours. So there are things that I didn't go into, but in looking at CBD, oftentimes when you look at the product of CBD, it's still, even though they're trying to purify it out, there still is THC in that product. It may be a small amount, it may be more, depending on how pure, how good their process is, but inherently there is THC with the potential to test positive as well.
A couple questions about the mom, and if she stated that she is abstaining or planning to abstain, do you take her at her word, or do you do some sort of toxicology test?
Thank you. I was running out of time, so I kind of glossed through that. I do not. In our group, we do not, because we believe in developing, the multidisciplinary team believes in developing at that therapeutic relationship. And so we work actively with moms and say, you know, we develop that relationship. The LC is working with that mom to establish and maintain the milk supply until we're ready to use. And it's an eye-to-eye conversation of, okay, have you stopped? Remember, we talked about the risks. Are we good to go? I do find that oftentimes moms that are not able to abstain, the nurses already have their antenna up. And if you respectfully question them on it, they'll own up to it and say, you know what, I couldn't abstain. And oftentimes they, based on their aversion to risk, will stop pumping because they can't stop using or utilizing the marijuana.
I think this is part of it, goes along with it. Do you have parents sign an informed consent to use their breast milk if the mother is using marijuana?
Since we don't use mom's breast milk when we believe there's a significant amount of marijuana, we do not. I'm not a fan of signing consents, the whole consent for formula and the term population as well. I feel like it's more respectful that we have an educated conversation and have that trusting therapeutic relationship. When you pull out a form that says you sign this saying that I told you you're going to hurt your baby using your milk, I think it undermines the whole process of being in the newborn intensive care unit and supporting both the baby and the family. And oftentimes when you advocate and say, this is what's best for the baby, most people will say, you know, unless they're chemically dependent, they're going to go, okay, wait, I don't want to take cough medicine. I don't drink coffee when I'm pregnant and breastfeeding. And so I think it can often, if you explain that there's concern and data, the problem that we suffer with, which I didn't talk about, was this perception of safety, because legal is safe. And that is a component that we do have to address by educating them on what is known and what is concerning about THC exposure and the developing brain.
Thanks. For moms with chronic use, should the breast milk be restricted for 2 to 4 weeks? Is that based off the half-life of the data?
No, this actually was when we made it, and we're actually going to be, I have a meeting coming up in the next few weeks to look at that Wymore paper that just came out in March. When we picked 2 to 3 weeks, we knew that users often have positive urine upwards of 4 weeks. And because of the sequestering in the fat, we picked 2 to 3 weeks because we felt that it was going to lower the amount of THC, but was a reasonable time that we wouldn't lose mom's pumping. And for anybody who's pumped, if you're pumping only, it is not a rewarding experience. And yes, we have moms that have to do that because they're in the NICU, but if you're pumping and then your milk's being sprinkled on a plant instead of being given to your baby, it is not a rewarding experience, and it is not going to be something you want to do for a prolonged period of time. So part of why we picked 2 to 3 weeks is we felt that it would allow for a decrease in the amount of THC in the milk. We didn't have any notion that we would have 0 THC. We were mitigating risk in saying we could decrease the dose by something. According to that Wymore paper, we're probably about at a half-life. So we've halved the amount of THC in the milk. So it's not based on it being gone. It's based on saying, how can I balance the likelihood of successfully maintaining a milk supply and not losing mom because we're going out too long versus trying to mitigate the amount of THC in the milk. And like I said, this isn't imperfect. There's no perfect answer because we don't have the data.
Thanks. A lot of questions about for a newborn nursery or for a well baby nursery, not the NICU. What approach would you recommend? What if you don't have donor human milk available?
Yeah, the term population is different. And it's one that I am highly unsatisfied with my options because they're going to go home. They're going to go home fast. So they need to be fed, and they're going home into an environment that may be having THC smoke. And there you're looking at, wow, I'm going to have a potential increased risk for sudden infant death. And so breast milk is probably the best approach. I believe that mothers should be extensively educated in the nursery and really given the understanding of, okay, there's risk to your baby, and taking it into you're advocating, we're doing the right thing for the child, and really educating on, hey, in your pregnancy, what did you, and I think the approach needs to be, in your pregnancy, what things did you not do because you were concerned about it potentially affecting the baby? And then when you educate them about the marijuana and say, we believe you should not breastfeed when you're using marijuana and would ask you to stop, but we do know there are benefits of breast milk. So in my experience, I don't develop those policies, but the approach is to educate and allow to breastfeed, when to establish milk supply, and knowing that the benefit of milk there may be more helpful than the exposure, especially if you can get mom to stop, and you would just tolerate the fact that there would be exposure until that dose is out of the milk.
Thank you so much. We have so many questions coming in, but I do want to make sure we have the time. So this is out of 168 responses. So I'll just go over this and then I'll turn it over to Bob to give us a wrap up. So what is your role in the hospital? Obviously, it's really varied. Lots of, looks like RNs and MDs and lactation consultants are the top. Does your NICU have written guidelines regarding breastfeeding or the provision of breast milk? It's really split here. You can see yes is about 40%, no 30, I don't know is 30. Does your hospital test for THC? Pretty much yes, in both the infant and maternal toxicology screens. If a mother admits to current THC use or has a positive toxicology test and no other drugs, would you allow her to breastfeed or provide breast milk to her term infant? The top answer is depends on a case-by-case basis at 38%, and then 31% yes. And then same question for the preterm population, depends or no actually went out here at 33% as well. And then at your hospital, is it usual procedure to consult with CPS when a mother has a tox screen that's positive for THC but no other drugs? Yes is listed at 38 and no is at 38. So we're almost at a tie there. So we just wanted to share that to provide a little bit of context about the audience on this call and what your fellow healthcare providers are doing and practicing. So Bob, I will turn it over to you.
Thank you, Caroline, and this is Bob Castro. I'm the NICU Medical Director at Salinas Valley Memorial Hospital and one of the Maternal Exposure or MADEX co-chair. Thank you, Christine. That was a wonderful presentation. It's great to hear from a fellow colleague who also has trained at Harbor UCLA. You remember that, Christine? Also glad to hear that you were only 8 years old in the 1980s and appreciate the Ridgemont High reference. Thank you to all participants for completing also the pre-webinar survey. Please remember, we are still hoping that your center, if it's not already participating, will participate in the statewide MADEX database. My and other centers who are participating have learned so much on how we can better care for infant exposed to substances in utero. We have started focusing on opiates, but as one of the MADEX co-chairs, along with Lisa Chai, Angela Wong, and Pam Aaron Johnson, we are discussing expanding the database in the future to include other substances exposures, including marijuana and amphetamines. But this can be done already at your specific center. So please reach out. We would love to hear from you. You will receive a link to an evaluation survey for today's webinar. Take a minute and complete it so that we'll know what you appreciated and what you would like to see in the future. Thank you for prioritizing and participating today. And a special thank you to Caroline, Tony, Nolan, along with their CPQCC colleagues for all of their services making the Maddox database a progressive success. So thank you, everybody. Caroline?
That's all, folks. Thank you so much. The slides, I don't think I showed this, the slides can be available here. They'll also be sent around in a follow-up email link. So be on the lookout for that. Thank you, everyone.